Alô, alô, bom dia a todos. Estamos iniciando mais uma reunião clínica do Departamento de Pediatria da Faculdade de Medicina da USP. A gente está voltando do nosso breve recesso no mês de julho, com bastante coisa boa programada já para esse segundo semestre, então continuem com a gente. Toda quarta-feira a gente entra aqui do nosso ICR, que é o Instituto da Criança e Adolescente do Hospital das Clínicas aqui de São Paulo. A gente entra ao vivo às 9 da manhã, com um conteúdo que certamente é relevante para quem tem interesse em saúde de crianças e adolescentes. Então, hoje, antes de apresentar a nossa palestrante, que hoje é bastante especial, queria agradecer a Marchione e o Thiago, que estão sempre aqui nos bastidores, dando um suporte inestimável, e agradecer também, hoje especialmente, a doutora Vera Koch, nefrologista pediatra, que foi quem fez o meio de campo para que essa reunião pudesse acontecer, e a doutora Lúcia Campos, que vai participar com a gente durante o nosso debate ao final. Então, obrigado, Vera, obrigado, Lúcia. Agradecer aos nossos professores titulares. Hoje eles estão ocupados em atividades externas, então a gente hoje não vai ter a presença deles com a gente, uma pena, mas estão sempre dando o apoio necessário. E agradecer a nossas diretorias, clínica executiva da instituição, sem o apoio também, isso aqui não aconteceria. Vou pedir para que vocês se inscrevam no nosso canal, e que vocês cliquem no nosso sininho lá para poder receber as notificações quando a gente está entrando online. Deixem os joinhas nos nossos vídeos, porque isso aí aumenta a nossa relevância, vocês sabem como funciona. E que vocês participem com a gente do nosso debate, enviando perguntas através do chat. Quiserem enviar perguntas em português, eu traduzo. Quiserem enviar em inglês, da forma que for melhor para vocês. Tá? Hoje eu estou aqui mais como intérprete do que qualquer outra coisa. Então, sem mais, agora eu vou apertar a tecla SAP reversa, tá? Para tentar apresentar a palestrante em inglês. So, thank you very much for all of the public that's watching us live here at YouTube. And I'm going to call to our screen Professor Beatrice Goilav. It's a great honor to receive you here. Professor Beatrice is medical director of pediatric nephrology of Children's Hospital at Montefiore and the University Hospital for Albert Einstein College of Medicine. She was kind enough to agree to present us a lecture about lupus nephritis. That will be very enlightening for us, for sure. And we thank you very much in the name of Pediatrics Department here at Faculdade de Medicina da USP. Thank you very much. I'm going to ask you, Professor Beatrice, to leave your slides at ready, and then I'm going to pass the word for you.
Thank you very much.
Thank you.
Thank you. Thank you very much, Dr. Alberto, for and everybody for allowing me to give you a talk about an update on pediatric lupus nephritis. So I'm a pediatric nephrologist, but I trained as an internal medicine rheumatologist before. So my passion has always been lupus. So I realized my passion is not adult patients, so I changed to pediatrics and never looked back. I was never happier than now. So today I will give you a little bit of an outline of my talk. We will have an overview of adult and pediatric onset lupus nephritis. There are some differences. We're gonna have a brief look at the pathophysiology because that is a whole separate lecture, a little bit about the diagnostic process, the management, and the outcomes, and what unmet needs there still are despite all the advances that have been made. So a little bit of history. I always like to look back in how did a disease get a name. So lupus, as you very well know, is the Latin term for wolf. And that appeared first in the year 860, and it was basically including all ulcerating skin conditions. And only in the 13th century, there was a physician who particularly described the erosive lesions of lupus, which reminded the scars of a bite of a wolf. So apparently wolves, when they attack, they go for the neck and they go for the face. And if someone survives, then they are left with similar scars as what lupus does to people if left untreated. In 1872, Dr. Kaposi recognized that the rash represented actually a systemic disease. It wasn't just a skin condition, but it took another 70 years to develop a test that could make the diagnosis of lupus, and that was the so-called LE cell. Later on, there was, as technology advanced, immunofluorescent tests discovered antibodies to nuclear materials, and so the ANA was developed. And finally, later, again, it was recognized that this was an autoimmune process as opposed to an infection or anything like that. So lupus, or SLE, affects every age, race, ethnic background, and socioeconomic status. It predominantly affects women of reproductive age, and it particularly affects, at least in the United States, and I'm sure you have the same experience in Brazil, Black versus white women. Children and adolescents make up about 20% of all the lupus patients. And children have a higher risk of developing lupus nephritis, and lupus nephritis is generally more aggressive in children than it is in adults. Here are some of the manifestations that you see of lupus. It can cause a variety of rashes. The malar rash is particularly famous. Please pay attention to the nasolabial folds, which are spared, and that is pathognomonic for the lupus rash as opposed to acne or rosacea or other rashes. They can have vasculitic lesions. They can have bullous lupus. They may have some overlap, and then they get Raynaud's, and they have arthritis. Babies born to patients with lupus can have an AV block because of RON-LA antibodies that can be present in the mother's blood, and that can affect the conduction in the heart of the child. As I mentioned, pathophysiology of lupus is a whole other talk. It is very complicated, but the basics are that this is a chronic disease. It is characterized by loss of tolerance to self-proteins, and as a result of that, the patients have autoreactive B and T cells. And clearly there is a genetic predisposition, and I believe there are more than 70 genes that have been described to be involved in increasing the risk of SLE. Triggers are usually any kind of noxious injuries to the cells that potentially can damage the cell and the nucleus and result in release of proteins that are usually intranuclear outside into the extracellular space. So UV light is a very common trigger, as well as a risk of flare. Cells that undergo apoptosis or necrosis because they release cellular components, and infections that can also result in necrosis. But in addition to that, microorganisms such as RNA viruses can have similar antigenic sequences that then cross-react with human autoantigens, and that can also trigger a new lupus diagnosis. So I don't know if you had the same experience in Brazil, but in the US, we saw a lot of new lupus after COVID. And basically the result is that these autoreactive B and T cells ultimately form autoantibodies, and those form immune complexes that specifically in lupus nephritis are the ones that are damaging in the kidneys, because these complexes get deposited and attract immune cells. So the diagnosis is not very straightforward because there's not a single test that can diagnose lupus. There are some more specific laboratory tests. So specifically, we look for an anti-nuclear antibody titer that is over 1 to 80, usually 1 to 160 minimum. Double-stranded DNA antibodies are relatively specific to lupus. And then there are intranuclear specific antibodies, such as anti-Smith antibodies that are relatively high specificity for the diagnosis of lupus. And complement levels are the other proteins that we test for that reflect the level of activity of the disease. In 1997, the American College of Rheumatology came out with criteria of organ involvement that are affected by SLE. And in order to make the diagnosis back then, you needed 4 out of 11 of these criteria, and they included organ-specific symptoms as well as laboratory tests, and the patients had to have a positive anti-nuclear antibody and a positive double-stranded DNA antibody. Now, with this diagnostic criteria, a lot of patients, particularly pediatric patients, actually were not diagnosed with SLE, even though they had it. I remember when I was a fellow in rheumatology, we would have patients who had kidney biopsies consistent with lupus nephritis, but they didn't have double-stranded DNA or ANAs. And so we couldn't make the diagnosis of lupus, so we couldn't treat them for lupus. So that was recognized actually quite a bit later that was a problem. So there were new criteria that were more extensive that allowed us to diagnose a patient without having all of these tests or these criteria fulfilled. So historically, we needed 4 or more criteria to diagnose the patients. But what was introduced in 2012 was that if somebody had biopsy-proven lupus nephritis and a positive ANA or positive anti-DNA antibodies, they made the diagnosis of lupus. And that made it much easier because, like I said, a lot of young people present with organ involvement before their serological disease actually becomes clear. So lupus nephritis is what we call the kidney involvement in SLE. About 40% of adults with SLE will develop lupus nephritis, and about 60% of children with SLE will develop lupus nephritis. So you can say that on average, half of the SLE patients have also kidney involvement. Children with lupus nephritis have a higher risk of kidney failure at 5-year follow-up than adults, so up to 23%. And a 19 times higher mortality compared with age-matched healthy children. So that is a very important finding. So the clinical features of lupus nephritis are really what you see with other types of glomerulonephritis, proteinuria, hematuria, which can be gross or microscopic. They have edema if they have nephrotic range proteinuria. They have hypertension, and they also have abnormal kidney function, could be slightly abnormal. They have hypocomplementemia and low albumin levels if they have a lot of proteinuria. The only way to diagnose lupus nephritis right now is by kidney biopsy. Now, the question is always, when are you supposed to biopsy a patient that you suspect has lupus nephritis? Now, I always say time is kidney, because several studies, and this is just one example of them, have demonstrated that if you delay obtaining a kidney biopsy and treating the patient for the findings on the kidney biopsy, these patients have a negatively impacted outcome over the course of several years. So here is an example of 91 patients who were on dialysis due to lupus. And one of the most remarkable risks for developing end-stage kidney disease was actually having a biopsy after more than 6 months of proteinuria duration prior to initiating the therapy. And that was independent of how severe the kidney disease was actually and how much treatment they received. So clearly time is very important. So the biopsy is percutaneous. We do this in children under sedation. Adults do it without sedation. There are risks associated, so obviously you always have to balance the risks and benefits of kidney biopsies. But in the case of lupus patients, the biopsy benefit is always present. Just a reminder for those who need it of what are the different classes. There are actually 6 classes of lupus nephritis, with the class 6 reflecting really a patient with end-stage kidney disease. So the tissue is usually completely fibrosed and there is not a lot of inflammation to treat. So class 1 is very mild. Class 2 has some mesangial deposits with expansion, and the deposits are those immune complexes that I mentioned earlier. Usually we see them by immunofluorescent, and then we have electron microscopy pictures which show us exactly where those immune deposits are lying in terms of the glomerular basement membrane. Are they inside? Are they epithelial or endothelial? And that is important because this is how you ultimately make the diagnosis of which class of lupus nephritis we're dealing with. So it is very important when you get a kidney biopsy that you send the tissue for all 3 tests. Now, in some countries, they don't have EM. So they have to rely on IF and light microscopy. It's not easy to always get very good tissue. So if you get very little tissue, you want to send everything to immunofluorescence because that is probably the most important one to diagnose lupus nephritis if you are in a bind with the number of glomeruli you obtained. The classification of lupus nephritis has undergone several changes. The initial one was in 1974 by the WHO, which has been revised a couple of times, most recently in 2012. And what has been added, in addition to the classes, was also the chronicity and the activity of the disease. And those are important aspects because it shows you how much inflammation there is, but it also shows you how much scarring there is. Sorry. And that is important because if you have a patient that has, let's say, somewhat abnormal kidney function, and you biopsy the patient and they have class 4 lupus nephritis, which is the one that is the most aggressive disease. If they have a lot of chronicity, so a lot of scars, but very little activity, so very little inflammation, that is probably not a patient who you will want to treat with cyclophosphamide and what other, very expensive biologics and things like that, because there isn't much to treat. So it is important to pay attention to that because every treatment also has side effects. So you want to make sure the patient benefits the most from the therapy you give and have the risk of minimal side effects. On the other side, if you have a patient that has class 4 and a lot of activity, that's the patient you really want to treat very aggressively, and we'll talk about the treatment. So the more recent classifications actually added more attention to the tubular interstitium. As you see on the previous slide here, the classification all goes by what happens in the glomeruli, but the 80% of the kidney volume is actually tubular interstitium. And this is where a lot of the inflammation and scarring happens. And we have gradually recognized that the more the tubular interstitium is affected, the more it predicts the outcome of a given patient. So now there is a lot more attention to that. I want to draw your attention to a registry that is a collaborative pediatric rheumatology research organization, which is called Childhood Arthritis and Rheumatology Research Alliance, or CARA, which has a registry of patients with all sorts of rheumatological disorders, including lupus. And there are two cohorts. There's one early one from 2010 to 2014, which is called the Legacy Registry. And there is an ongoing one that was started in 2017, which is a prospective registry. One of the major utilizations of these two registries was to really determine some changes that have occurred in the phenotype of lupus that we see now that we have more biologics, more therapies that presumably are more effective in treating the disease, but also to learn, has the demographics of lupus and lupus nephritis changed between these 2 decades. So one of the things we were interested in was to learn about whether the onset of lupus nephritis in relationship to the time of the diagnosis of SLE has changed. One of the things that we saw early on and that we were teaching our students and residents was that a patient with lupus will most likely develop lupus nephritis within the first 5 years of their diagnosis of SLE. And so we wanted to know if this was still correct. And when we reviewed the registry, we actually saw that indeed 93% of patients that were diagnosed with lupus nephritis were diagnosed within 2 years of their SLE diagnosis. The C stands for childhood. 88.4% were actually diagnosed within 1 year. And only very few percents were diagnosed later than that. That doesn't say that, that doesn't mean that someone who has had lupus for 10 years will never develop lupus nephritis. We actually have a couple of patients that develop lupus nephritis after more than a decade. So always be on the lookout, always screen the urine of these patients. But that's generally the time frame. It's a very early onset. And typically the way that lupus nephritis manifests is with proteinuria. Proteinuria is our biomarker in nephrology. We'll always look for that. It has not a lot of specificity with regards to a disease. It can signify early, late, or acute or chronic glomerular disease. It can also mean tubular injury. Sometimes it's not even of renal origin at all, such as, for example, amyloidosis or patients with monoclonal gammopathy, but that's usually in older patients, not so much in children. There has been a lot of a debate at what level of proteinuria should you biopsy a patient, and that's true for many kidney conditions. But especially in lupus nephritis, our experience has been that adult patients with lupus nephritis were biopsied typically when their urine protein to creatinine ratio was over 1. In pediatrics, we are less tolerant of proteinuria, so we would biopsy the patients quite a bit earlier. The other question in terms of proteinuria is also, how do you collect a good urine specimen that reflects truly what happens inside the kidney? So when the time of the day that the patient provides this sample is actually important. As you may know, a lot of adolescents and young adults have what we call orthostatic proteinuria, which is a benign type of proteinuria that occurs usually with hemodynamic changes within the glomerulus and is really not a condition, not a disease. And should you collect urine for 24 hours, or is a spot urine enough? The gold standard is really 24-hour urine collections, but there was a study that was done to look at the correlation of the urine protein to creatinine ratio between 24-hour urine collections and spot urine collections, so first morning specimen typically, to avoid the orthostatic component. And it looks like there is pretty good correlation. So you don't have to ask the patient to collect urine for 24 hours. Typically, clinical trials and new drug studies do require 24-hour urine collections, but even those are now moving more towards first morning urine collections just because it's easier. So, as I mentioned, the urine protein to creatinine ratio matters, and that was actually found in a study, in a multi-center study that was sponsored by the NIH in partnership with commercial funding. To really accelerate the treatment development in lupus and lupus nephritis. So we were part of that in looking at what level of proteinuria should we biopsy patients with lupus nephritis. So in pediatrics, we always use the cutoff of 0.5. And it turns out that it's a pretty good cutoff. Because you can capture all of the classes basically in a patient like that. The chances that you're not going to find anything in the kidney of a patient with lupus who has a urine protein to creatinine ratio of more than 0.5 is very low. You will find something that you probably have to treat. And so the adult people started looking at that same issue. And I remember when we started enrolling patients into this cohort, I mentioned to the adult rheumatology people, I said, you're including only patients with a urine protein to creatinine ratio over 1, but we actually find a lot of pathology on the pediatric side below that. So they started including some patients with a urine protein to creatinine ratio of 0.5 and above. And lo and behold, they actually found proliferative and membranous lupus nephritis. So both the aggressive and probably the little bit less aggressive types. So definitely proteinuria doesn't always correlate with the severity of the disease. So it's important to have that. Moving on to therapy, I will just briefly go into that because, again, this is another whole talk that I could speak about for several hours. But basically, the therapy of lupus nephritis is divided into 2 stages, so to speak. The induction therapy, which is typically the first 6 months, that the goal of that is to quickly reduce all the inflammation that occurs in the kidney. And the reason why we need to do that is because if you leave inflammation untreated, it will invariably result in scar tissue. And scar tissue is a big problem because kidneys they cannot regenerate, certainly not the glomeruli. The tubules have some regenerative capacity, but not once they are scarred. And I will show you why this is really important to prevent scar tissue. So in the US, there are several protocols that are classically being used. The NIH protocol is a high-dose cyclophosphamide monthly infusion for 6 months. All of that is on a background of high-dose steroids. The Euro-Lupus protocol is a shorter course and only provides 50% of the dose of cyclophosphamide of the NIH protocol. So it's given every 2 weeks instead of monthly. But there are also just 6 doses. So after 3 months, the patient is done. again with a background of steroids. And then there is a third option, which has turned out to be equipotent to the NIH protocol, particularly in women of Black ancestry, and that is given with MMF, so mycophenolate mofetil, which is an antimetabolite, again on a background of steroids. So high dose, it means usually around 3 grams for adult size patients. And then the second phase of the therapy is the maintenance phase. And the goal of that is to prevent flares and ongoing inflammation that may not have been addressed yet completely by the induction therapy. Ideally, at that point, the patient shouldn't be on any steroids. We're talking 7, 8, 9 months after diagnosis. Really, the goal is to lower or remove steroids entirely as soon as possible. The patients are typically on mycophenolate mofetil. If the patient wants to get pregnant, they have to let us know. They actually have to sign an agreement with us that as long as they are on MMF, they are not going to get pregnant, and they have to use 2 forms of contraception because it is very teratogenic. If they tell us, look, I got married, I want to have children, we have to change them to Imuran or azathioprine, which is a very good antimetabolite, but typically is considered too weak for lupus nephritis. So perhaps you want to have a conversation with the patient about the potential of maybe postponing their plans a little bit, get the patient into a better place, especially if their lupus is still active, which also diminishes the ability to get pregnant and carry the pregnancy to term. So avoiding complications may be one of the incentives to keep the patient on MMF for a little while longer, or you choose and go to Imuran, but explain that there is a high risk of flare. Obviously, we always use renin-angiotensin-aldosterone system inhibitors, so that's ACE inhibitors or angiotensin receptor blockers. Hydroxychloroquine is the vitamin of lupus. All of our patients are on hydroxychloroquine, even when they're on dialysis. We give half the dose on dialysis because the clearance isn't as good of the drug, but it has shown benefits from a systemic disease. So someone who is on dialysis, their kidneys cannot be salvaged anymore, but they can still have disease activity anywhere else in the body. And transplanting a patient in the setting of active lupus is really not a good option. So you want to keep the disease in control as much as you can, and hydroxychloroquine is actually very good at that. And then we also give supportive care. If they are very nephrotic, we give them diuretics, we give them lipid-lowering agents, and we give them vitamin D and calcium, etc., to prevent bone loss. So I mentioned to you that one of the goals that we have with induction therapy and aggressive immunosuppression is to reduce the risk of damage in the kidney from lupus nephritis. So, and the reason why is because damage from lupus nephritis correlates with inversely with the life expectancy of a patient that has lupus. So here is the life expectancy in years. So someone who is a girl who is born today in the US has a life expectancy of 85 years. A boy that is born in the US is 78 years around. A lupus patient who is born today has a 65-year life expectancy. But if someone has SLE with kidney disease, and particularly with kidney damage, that is the lowest line right here. And look at this age. So we're talking about someone who's 14 years old. If they have scar tissue in their kidney from lupus nephritis, their life expectancy has been cut significantly short. So instead of being expected to live another 70 years, they will only live another 32 years. And this is not an exaggeration, and this is not data from the 19th century. This is 2013, so just a little bit over a decade ago, and this has not changed a lot. And I have seen that with my own eyes, and I'll get to that a little bit later. So one of the reasons why kidney damage is such a high mortality risk is because patients who have chronic kidney disease have a very high risk of adverse cardiovascular outcomes. So that also cuts down in life expectancy. And so, for example, a patient with lupus who is on dialysis and let's say is also Black, basically they end up having a very short life expectancy because of that. So the patient with who is on dialysis, irrespective of their underlying disease, actually, has a 30-year-old patient on dialysis has the same life expectancy as an 80-year-old who is not on dialysis and otherwise okay. So that's very important to know, because dialysis independently poses a risk to the patient for their survival, and that's because dialysis is not perfect at replacing kidneys. So we're talking a lot about adults here. So what about children? How do children do globally? When looked at a review of published data overall, what are the kidney outcomes of children with lupus nephritis? And this is a group in the UK that looks at various published outcomes data. Obviously, it's not a perfect way to look at it because every data set is a little bit different, but all in all, the 5-year mortality rate for childhood lupus was reported to be around 4 to 23%. Obviously, depending on age and at disease onset and what population was studied. The overall 5 and 10-year survival rates in an 8-year span are very high in high-income countries, but significantly lower in low and middle-income countries. And even within a high-income country such as the United States, for example, where I practice in the Bronx, we have a very low, one of the poorest population in the US, and the outcomes can be more similar to this, even though we are in a high-income country. Now, data from published articles is difficult to interpret, so there was an effort to actually look at an international cohort of close to 400 patients that was very recently published in Pediatric Nephrology, looking at, and actually your boss was part of it, was to look at what are the findings in kidney biopsies of children with lupus, and how were their outcomes, and what were risk factors for adverse outcomes. And that is very important. You want to know when you speak to your patient about what are the findings at diagnosis that are particularly concerning and that push you to be more aggressive in your therapy than you would be with other patients. So overall, the remission rate varied to some extent by class of lupus nephritis, which is understandable. But what was interesting is this is 100% remission. So this means all the patients have zero lupus disease activity after 2 years. Very few or none of them really reached that stage. So this tells me that there are always patients with active lupus nephritis. And these are from various different countries, including the US, including India, including Brazil, the UK, Japan. So this was a very reflective cohort of from many countries. And it turns out if the patient has anemia at presentation, that is one of the major drivers of adverse outcomes, actually. Obviously, there were some other findings as well, including the biopsy class, but they were actually not as correlating with the outcomes as other parameters here. And so I think also having abnormal kidney function at presentation is a risk factor for more adverse outcomes. So my major question after reading this paper was, why are not all the children with lupus nephritis achieving remission? I mean, we biopsy them earlier than adults. We treat them very aggressively. We follow them very closely. We don't let them slip away. You know, we really do everything for them. The parents do everything for them. So are there any other predictors of outcomes that we are not aware of? Are there factors that affect the remission rates? Do we need new therapies? Or are there any barriers that could allow us to improve outcome that we are not sufficiently addressing? So there was some other study that was published a few years ago showing the response rate of a patient's lupus nephritis and their outcomes. So one of the things that they looked at was how well did they respond to the initial therapy, and did that predict the risk of relapse? And it didn't. So a patient can go into complete remission, but they're still at very high risk for relapse. The other part that was interesting to learn was that the initial response to therapy is actually associated with kidney survival. So the 5-year survival is 80%, so meaning kidney survival that they don't end up on dialysis. The 5-year survival is 80% if they had a complete response versus 54% in non-responders. And non-responders are patients who literally have resistant disease, and you have to be very aggressive in your therapy about it. One of the things we looked at in our center was, are there other factors that are extrarenal that affect the mortality of our patients? And so we looked at ambulatory blood pressure patterns in children, adolescents, and young adults that had childhood onset SLE and had normal office blood pressures. So we had 25 patients, 18 of whom had lupus nephritis. And interestingly, we found abnormal ABPM patterns in patients with lupus that didn't have lupus nephritis. And certainly we saw some abnormal ABPM findings in patients that did have lupus nephritis. So one of the things to learn is probably that even before a patient with lupus is diagnosed with lupus nephritis, it is very important to pay attention to their blood pressure. And even if it is normal, it's probably worth screening them with ambulatory blood pressure monitors to make sure that they don't have any nocturnal hypertension or other abnormalities which can ultimately affect their cardiovascular risk. In addition to that, we know that genetics, I mentioned to you, there are over 70 genes that are associated with risk of developing lupus, but then there are actually genetic disorders that can affect the outcome of a patient diagnosed with lupus. I'm sure you have heard of the apolipoprotein L1 or APOL1, which confers protection from sleeping sickness in patients with of African American descent or African or Black descent, but it results in an increased interferon response when a patient has an infection, and it seems to really damage certain parts of the glomerulus, particularly the podocyte, which is one of the cells that sits on the glomerulus and is an important part of the filter. So these podocytes get stressed very quickly, and then they detach, and that results in proteinuria and ultimately in sclerosis of the glomerulus and progression to end-stage kidney disease. About 13% of the US population is homozygous for the mutated forms, which are the risk alleles. There are two alleles, G1 and G2, which are called the risk alleles. And they develop HIV-associated nephropathy and even APOL1-mediated kidney disease, which is a form of focal segmental glomerulosclerosis. Very aggressive, very difficult to treat. But you have to have both risk alleles, so the patient has to be homozygous for these risk alleles in order to experience that kind of disease. It turns out that in lupus nephritis, and this was actually a study done in Brazil, adult patients, it turns out that even when they are just diagnosed with lupus nephritis, on their first biopsy, they are found to already have interstitial fibrosis. So remember, that's the tubules on that first biopsy. So it seems like one risk allele of the APOL1 gene is already enough to already enhance the inflammation in the kidney of these patients. And that is not very surprising, because we know that interferon is one of the major drivers of lupus and lupus nephritis. So we actually looked at this in our cohort in pediatrics, and we did not see that finding, but it was just a small, our own patient population, only 12 patients. So we have to expand that into other centers, and that could be a great opportunity for collaboration. We need also better tools to assess the tubular interstitial space. I mentioned to you that this space was added as an important area to look at for the pathologist and inform us about inflammation and scarring much later in the course of the classification of lupus nephritis biopsies. And one space in nephrology where everybody looks at the tubular interstitial space is actually in transplant kidneys when you look for rejection. And so what we did was we took the classification, which is called the Banff criteria, for damage from rejection in transplant patients, and adopted it and applied those criteria to lupus patients. And we had about 230 pediatric and adult patients, and we basically found that in areas that are scarred or non-scarred tissue that have severe inflammation correlated with risk of disease progression. So it's not only looking at just inflammation alone, but inflammation within scar tissue actually correlated with more rapid onset of kidney function loss. And I think this is one of the important aspects to look at. And I will tell you that right now the International Society of Nephrology and the Renal Pathology Association are looking at revising their criteria again to diagnose lupus nephritis and make it a better predictive tool. In terms of therapies, oftentimes we add rituximab to our patients who are either struggling with taking their medications as they should, and that is very common, and or they are not responding to the therapy. Rituximab is a biologic. It is an anti-CD20 drug. It had been tested in several cohorts with lupus nephritis, small studies, mixed outcomes. One of the things we know is that it's generally well tolerated. And in our population, it seems to be helping with keeping the disease at bay, not completely controlled, but at least to some extent compensating for the lack of medication adherence. There are many therapies in development right now. The most spoken about is giving a CD19 CAR T cell therapy, which had remarkable findings in a small study out of Germany. Specifically, what was interesting is to just explain to you what these patients are getting. They are getting like a mini bone marrow transplant. They get their own cells harvested, then they undergo some chemotherapy close to what bone marrow transplant patients get, no radiation though, enough to make space for new cells. And then they get the T cells that are modified to attack CD19, so B cells. And they are basically sort of resetting their immunostat. They are wiping out their autoreactive B cells, and they seem to be replacing them with protective B cells. So normal, like you and I have, that fight infections, not our own body. And one of the patients, after 17 months of follow-up, just on no therapy at all, only some supportive care and hydroxychloroquine, had complete remission for 17 months out of that mini bone marrow transplant. Very interesting findings. However, it is a tough treatment. Patients can get very sick from it, but that's definitely something interesting in development. And there's also a selective immunoproteasome inhibitor that is also in development. There are many others. There's no time for that right now. But one of the things I wanted to briefly address is also the barriers to improved outcomes. I mentioned to you, we give our patients everything we have. We see them frequently. We diagnose them early, yet we still have patients that are still have disease activity, that have flares. And it turns out that the problem to that has nothing to do with their diagnosis or their disease per se or anything else, is that there are a lot of comorbid conditions. Obesity is a big one because patients are on steroids, they gain a lot of weight, they can't lose it again, they become depressed, and mental health really has become a huge issue. With the pandemic, everybody has more mental health issues, but this population with chronic disease has experienced particularly increase in mental health. One of the big reasons is also pill burden. Think about being, 20, 21, you want to go out, you have a tiny little purse. Who can stuff 18 pills in there? Who wants to do that? So they go out and they leave the pills at home, so they don't take it at night. They come home, they're too tired to take the pills, and so this is how this non-adherence perpetuates. And if they do that long enough, they are going to get a flare, unfortunately. The side effects of the therapy, if you ask patients with lupus, what is the worst part of your disease? They will tell you it's the side effects of how they feel after they take their medications. They gain weight, as I mentioned. They have a risk of opportunistic infections. They cannot respond to immunizations. They develop osteopenia. We have 18-year-olds with hip replacements because they had avascular necrosis or other significant bone damage from not even that long steroid therapy, but it seems that some patients are more prone to issues with bone density, perhaps because they go into therapy with a lower bone density to begin with than others. So it's a huge problem. They miss a lot of school. As a result of that, their performance in school is not that great. So they cannot achieve their full potential in many ways. So as I mentioned, mental health is a huge issue. And that's not just in the US. This is in India. This is in China. So 60% of lupus nephritis patients report some form of mental health issue. So it's important to overcome these barriers, and one of the things is trials in pediatric cohorts, of which only Benlysta has been studied in children. All the other medications have been taken from adults. Better cardiovascular, better understanding of risk factors for mortality, and interdisciplinary clinics. We really have learned that interdisciplinary clinics are extremely important. You see the patient at the same time with your colleague, you minimize the travel of the patient, you minimize miscommunication, and it's a great learning experience. So this is our interdisciplinary lupus nephritis clinic. We have a rheumatologist, a nephrologist, a psychologist, a social worker, a nutritionist, and we have what is called a community health worker, which is a person that calls the lupus patient and arranges for their transportation to an appointment and reminds them of appointment, and those have been very important. So with that, I want to thank you for your attention. You can email me with questions if you're too shy to ask now. And my dog Nutella will be happy to answer any questions.
That's very, very cute. Thank you, Professor Beatrice. Thank you for your participation. It was very clear, very important information that you bring us. So thank you very much in the name of the pediatrics department of our institution. We have some good questions arriving by the chat, and we have Lucia here at backstage, who's going upstage in a few moments. And I'd like to begin with a question of my own. I work with teenagers at my office, and we know how hard it is for teenagers to adhere to treatments and to understand and comply with our orientation. So how do you deal with teenagers and young adults that might be a little hard to get into treatment properly? What's the multidisciplinary team that you have for this, and what's the strategy?
Yeah, we don't have a magic formula. It's spending a lot of time talking to the adolescent patient and the young adult. We actually follow patients up to the age of 21 in our hospital, but lupus nephritis patients get followed up to the age of 26. And the reason is because up to 26, their brains are not very rational. Most of the times they don't see the future. They don't have the insight of understanding that if they don't take their medicine today, they will have a flare in 3 months. So we actually try to engage them with psychologists. Oftentimes, there is an underlying level of depression and anxiety that can manifest itself as, for example, non-adherence to medications. We try to work with them to teach them insight. Many of them say, I'm busy, I forget, I don't know, I don't know why this happens. We have them download a lot of apps that help them remember. It's like some of the apps are like a game where you get points if you take your medicine on time. There are others that give you reminders. There are a lot of apps like that help us with that, but a lot of it is really talking them through the consequences, trying to teach them. And eventually, we see that after several years of having these same discussions, we see sometimes it clicks in the brain, and then they finally take control over their body. But it's very time consuming. And you need multiple people to remind them. This is why we also have the community health worker that helps them with getting refills on time and remembering to call when they run out of refills of the medications, and remind them to come to our appointment. It's a struggle. They don't like to come to the appointments because we yell at them. We tell them, you're not taking your medicine. You know what's going to happen to you. And so it's a bit of a vicious circle. So our patch to that is putting them on rituximab, which is not a great solution because we immunosuppress them more, but ultimately that kind of keeps them at a safer level than if we rely on them taking their medications entirely. We monitor drug levels. We monitor hydroxychloroquine levels and mycophenolate levels, and that helps with us knowing if they take the medicine.
Nice. It's very interesting you say that you keep looking into those patients until they are 26, because the definition of adolescence is changing with time, and we are starting to understand the third decade of life as more closely related to the second decade of life than to the fourth decade of life. So this is something that we agree here.
Yeah.
So I'm calling.
Sorry, I was also asked about transition. How do we transition these patients? And that is a big problem. I will say that we have at our institution, we are lucky in many ways because we work closely with the adult rheumatology and nephrology space, and we have presented some of our successes with our lupus nephritis, the interdisciplinary clinic, which I started when I joined faculty at Montefiore, and so they got inspired by us. It's a financial nightmare for a hospital because you're using 2 doctors at the same time to see one single patient when each could actually see 4 patients. But the institution has recognized the importance, and so now they have a similar model on the adult side. It's not completely interdisciplinary, but the rheumatologist and the nephrologist are next to each other at the same time, and that has helped a lot with us transitioning to specific physicians that are trained in treating lupus and lupus nephritis. And we prepare our patients starting at the age of 12. There are checklists to teach them about transition to adult care. But yeah, like you said, it's the third decade of life is no better than the second. I agree.
That's it. Thank you. Thank you very much. So I'm calling to our screen Dr. Lucia Campos. Dr. Lucia is the head of our pediatric rheumatology team here at our hospital. Thank you, Lucia, for coming. And would you like to ask some questions to Professor Beatrice?
Yes. Thank you, Dr. Beatrice, for this brilliant presentation. It is a pleasure to receive you in this meeting and learn more about the experience of your service in lupus nephritis. I have to say that lupus is my passion too, and I'd like to tell you about that. We have in our service now about 100 patients with lupus, and the renal involvement is the greatest issue of these patients. About 85% of our patients have lupus involvement at some point of their disease, and it's amazing. But at presentation, 12% of them have acute renal failure, and 2% then have already chronic renal failure. So this is you have because of that you have on average 5 patients hospitalized for the disease complications, especially lupus nephritis. So the pediatric nephrology unit is one of our greatest partners in managing these patients. One of them, but many other specialties are involved. So to start the discussion, I would like to ask you, what are the reasons that stimulate your service to create interdisciplinary clinics for lupus nephritis?
Thank you. Yeah, no, you're right. It's not, not just nephrology and rheumatology. We also work closely with a dermatologist. We also have orthopedic surgeons. We have gastroenterologists, just because there is such a complex organ involvement. What really drove us to generate this clinic was that we realized that we were diagnosing the patients too late. We were biopsying them very late because they would be followed by rheumatology, notice they have proteinuria, and it could take up to 2 to 6 months until they got a biopsy. And then another few weeks until they got started on therapy. The Lupus Nephritis Clinic has allowed us to biopsy them within 2 weeks of onset of proteinuria, and then treat them very quickly. One of the other reasons why we are following them up to 26 in this interdisciplinary clinic is that we learned, we had a few patients. We had actually 3 young women who transitioned to adult care and died within 2 years from cardiovascular complications, stroke, heart attack. That was their cause of death. So we realized that we have to keep having that tight control on them for longer, and have obviously also cardiologists involved. Patients have lupus carditis. They have neuropsychiatric lupus, so we have neurocognitive testing for these patients, just to understand what their level of function is, that we can optimally transition them ultimately to adult care. And that was one of the major drivers. And it's also an excellent learning experience for our trainees, right? So the residents love it because they see both specialties, how we think, and that's actually a really good way to address their disease, and also maintain an environment of research. Combining that, we use the clinic also to collect specimens for a biobank. So we have we have urine, plasma, and other biological samples that we can always go back to if someone is interested in research.
Right. I'd like to ask you also, what's the percentage of your lupus patients that undergo kidney transplant, and what is their prognosis?
Yeah. So I will say that we actually have not had patients ending up on dialysis. So this clinic we started in 2012, and we had one patient who had to go on dialysis for 7 months, and then came off dialysis and is still off dialysis 5 years later. Not with great kidney function, I will say, but we have been fairly successful in keeping them off dialysis. The problem is they die before they end up on dialysis when they transition to adult. But in terms of percentages, I think historically we probably had around 5% of patients ending up on dialysis and needing transplant. And they had, depending on how well the disease was controlled before they got the kidney transplant, they had a relatively good survival rate. But unfortunately, they have these moments of crisis when they don't take their medications, and unfortunately that not only affects their lupus, but they also lose their transplant from that, and that has been a huge problem. But fortunately, we don't see that as much in the pediatric side. I think we have a very good network of primary care physicians who recognize that patients have a systemic disorder, and they refer them to us relatively early on, most of the times within the first 6 months of their disease onset. And that helps a lot in preventing this damage. So we are lucky in many ways because we have excellent primary care physicians.
Very good. And do you have access to these new immunobiological drugs available for the treatment of lupus nephritis, such as anti-interferon or the new anti-CD20? And
Yes.
what is your experience with them?
Yes. So we have anifrolumab is the new anti-interferon drug. Yes, we actually have access to it because it's approved in adults, and most of our patients are 18 and older. So we do get, and we started 2 patients on it that had severe skin and kidney involvement. And it's like a miracle. Their skin is amazing. Their kidney disease is fairly well controlled. It's unfortunately an infusion every 2 weeks, which is difficult, but it really works. It really works. So it took us a long time to get the first patient started on it. And she had terrible scarring alopecia. And now her skin looks better. I mean, because it was kind of late when we started, the hair is not growing back, but at least she doesn't have this red skin all the time. And some of the hair is growing back, and her kidney function is also a bit better controlled. We have patients who are allergic to rituximab or develop, I don't know if it's drug antibody or something like that, but we have, I think, about 5 patients with obinutuzumab, that is the new CD20 inhibitor. My experience, it's good, but it's not much better than rituximab. So we don't say, oh, you failed rituximab, let me put you on obinutuzumab because that's so much better. That I would not make that switch. If the patient tolerates rituximab and it works okay, I would keep them on it. It doesn't seem to be so much better than rituximab. Maybe it works a little faster because it has better tissue penetration. So it can get into that tubular interstitium of the kidneys where the long-lived plasma cells are sitting. But it's not, we don't see greater rates of remission than with rituximab.
Thank you. Alberto, I think there are no other questions from the public.
Yes. Let's read the questions from the chat. Some good questions. So first, Karelia has written us about how do you make patients and families understand that lupus has no cure and many treatments might be necessary, many trials of treatments might be necessary with possible side effects.
Yeah, that is a very, very difficult conversation, and that's an excellent question because we have that every single time. I don't know how much misinformation is playing a role in Brazil, but I can tell you then that in the United States, people are very mistrusting of doctors, especially with COVID, because they were misinformed about vaccines. Unfortunately, this misinformation has transitioned into other conditions other than COVID and vaccines. And so a lot of people actually believe that there is a cure for lupus, but the government and doctors are hiding it because we want to make money. So that is the first barrier that we have to overcome and explain to them. It takes a lot of conversations. So, for example, just starting mycophenolate mofetil, I cannot start a patient on the first visit. I have to educate them. We actually have slides, a PowerPoint presentation that we give to the families and to the patients, and explain to them how complex the disease is. And we also explained that every patient has their own lupus, so to speak. And that we, just like they have a different pattern of disease, they also have a different approach that they need, different drugs. One of the things that has helped a lot in our experience has been to have a lupus support group. So we have patients with lupus that meet together at 6 in the evening, separate from doctors. They are not even in the hospital. It's arranged by our social worker, and they talk to each other. And typically there are patients, I think all of us have the 1 or 2 patients which understand what lupus means, understand why it is important to take the medications, and are willing to teach other patients about how important it is. And those are the most effective teachers because, they have the disease, they went through everything, they made the same mistakes, and they have learned from the mistakes. And they are the most convincing teachers. So I highly recommend, all you need is a room, the patients, and some pizza, and that works.
Adolescents start to listen more to voices that are not so familiar to them in the adolescent phase. So maybe if they listen to their peers, their equals, it might be more effective.
Absolutely. Certainly. Yeah.
Perfect. Now we have 2 questions from Andrea. Andrea is our head of pediatric nephrology here at our institution, so it's very good to have her here with us and sending like hard questions that I don't have a clue of how to answer, but maybe Professor Beatrice can help us with that. So Andrea wants to know how to manage a child with kidney biopsy demonstrating full house pattern in immunofluorescence, but does not fill the criteria for SLE.
Yeah. So I'm just curious, do you have electron microscopy as a routine on tissue?
Yes.
Yeah.
Yes.
Okay. Yeah. So one of the things we have seen is what we call now lupus podocytopathy, which is not a classifiable form of lupus. These patients typically present with significant nephrotic range proteinuria, and but at the same time they actually respond fairly quickly. So these patients we actually treat these patients with CNIs, with calcineurin inhibitors such as tacrolimus. I prefer not cyclosporin just because of the cosmetic side effects, but they respond actually quite nicely to tacrolimus. I put them on for maybe most 9 months because it's a nephrotoxic medication, and we basically treat. Once they are in remission with their proteinuria, we keep them on for another 6 months, and then we taper it off. And they seem to be responding very nicely to it. But yeah, it's hard when you have patients that have incomplete criteria. But that's when we call them lupus podocytopathy, and then you still have the word lupus in there. There is no code, specifically for lupus podocytopathy, for an ICD-10 code. But we do call them still SLE with renal involvement, and that allows us to prescribe some of the medications. I hope that helps.
Yes, do you want to comment, Lucia, about this?
You have this kind of patients from time to time, and in the end, even if the patient didn't fulfill the lupus criteria, we normally treat them like a lupus patient because it's autoimmune disease anyway, and you have to control the process, and you know that you're gonna need to use this immunosuppressant drugs.
Thank you. Now, one even more complex question from Dr. Andrea Watanabe about the apolipoprotein 1 risk allele. So Brazil has a very admixture population. Do you think the apolipoprotein 1 risk allele status may be used for the risk stratification of lupus nephritis and for the decision of therapy?
I think absolutely yes. We have that same type of population, like I mentioned. I think the finding of tubular interstitial disease at the first diagnosis, as the first biopsy, specifically tubular interstitial fibrosis, is very, very concerning. I think that this is a very important risk factor for progression, and what is the scariest part is that you don't need two alleles, you need just one allele. The question is, how easy is it to get genetic testing, right? I think that has become for us in the United States much easier. We have various companies that are competing with each other to make the genetic testing cheaper. They come out with panels that are kidney specific, and that has made it for us very easy to identify these patients. I specifically use the genetic information, especially if I have homozygous APOL1 patients, to actually be more aggressive in terms of preventing cardiovascular disease. I put them on SGLT2 inhibitors. I am very aggressive about controlling their blood pressure. There are no specific therapies for patients who are who are homozygous for APOL1, but there are therapies in development right now, not in lupus, but I have spoken to them about how important it is to look at lupus patients because they don't even need two alleles to have a higher risk of progression, and they said once they are done with their first study and they are able to get this drug approved, they will definitely start branching out into other kidney diseases, and lupus is high on their list because it's the same population that has severe lupus and has these APOL1 risk alleles. So absolutely, yes, and yes. It's a driver of risk stratification, and for me, also of therapy. It's right now very non-specific therapy, but definitely something I would consider.
Perfect. Lucia, do you want to comment?
Yes. You commented during your presentation that you studied this genetic APOL1 in your population. You found it was you said a smaller group, and it would be nicer to have a multi-center study. And I think this can open a door for future studies. And you could share our patients, and I think it's going to be very important because we have some patients that's very, very severe, and they don't improve even with all the immunosuppression use. So maybe these are the kind of patients that even with this mixed population we have here, probably they can present this kind of genes. So it's going to be very interesting to start in the future.
Yeah.
Excellent. I suppose we are getting to the end of our time. It was a very profuse lecture and question and answering here at our clinical reunion. Thank you very much for your participation, Professor Beatrice. Lucia, thank you very much for coming. You're a very special person to all of us here in our institution. And thank you for all who watched us live or who are watching our recording later on. Thank you for those who sent questions. And I suppose we are going to finish now. It's too bad the lecture keep going because the discussion is so nice. But thank you very much, Professor Beatrice. And we come back next week with another very interesting theme. Next week we are talking about how human milk is a live food. It's a live food. That's the name of the lecture. Human milk is a live food. So you come back and we meet again. So goodbye. Thank you very much.
Thank you very much. Bye-bye.
Thank you. Bye.